Hello everyone, I'm Dr. Darsh Shah.
And I'm Dr. Altamash Raja.
And welcome to Medicine Redefined,
a podcast where we will explore the often overlooked but necessary components of health, what we consider to be the fundamentals.
We will investigate topics and practices that can give you and your patients the best chance to optimize a healthy lifestyle. It's time to move the needle forward and put the health back in healthcare. Before we get to today's episode, I want to take this time to talk to you all about learning medical Spanish. Now, if you're a healthcare worker, you already know what an asset it can be to have Spanish in your toolbox. There's no need to call the glitchy translator line or pull out Google Translate on your phone or find that one colleague who is fluent. It makes for more comfortable and authentic encounters with your Spanish-speaking patients. Now, while I may be able to get by with just 4 years of Spanish in high school, I want to be able to truly connect with my Spanish-speaking patients, to let them know that I am able to communicate in their natural tongue. Now, this is where my friends at Common Ground International come in. They have been teaching medical Spanish to healthcare students and healthcare professionals since 2003. Their mission is to impact communities through language. Now, twice a year, Common Ground International offers a free 10-day masterclass that helps you take a medical history and perform a physical exam in Spanish. Not only that, but you're going to walk away with a customized learning plan to improve your medical Spanish over the next 6 months. And that's not all. After you complete the Medical Spanish Masterclass with Common Ground, you'll earn 4 free CME Category 1 credits. They only offer this masterclass twice a year, and the next one is coming up very soon on Friday, August 26th. So make sure to mark your calendars. If improving your medical Spanish is one of your goals, and it doesn't matter if you're a beginner, intermediate like me, or advanced, you need to join Common Ground Medical Spanish Masterclass. You can get all the infos of dates and scheduling on their website at www.commongroundinternational.com/masterclass. Hope to learn Spanish with you. Our guest today is lifestyle psychiatrist Dr. Sarah Pospos. She completed her psychiatry residency as a chief resident at UCLA-Kern and has published extensively on burnout and depression at UCLA, UCSD, and UCSB. As a perinatal and sports psychiatrist, she is devoted to helping others feel their best again when dealing with burnout, depression, anxiety, and other common psychiatric challenges by incorporating lifestyle interventions, things that we talk about all the time on this podcast, things like sleep, nutrition, stress management, and efficient time management, especially as Dr. Pospos is a full-time psychiatrist and a mom of 2 under 2 herself. She currently serves California patients in her private practice via telehealth. And for the non-California residents, she offers additional free resources at www.lifestyletelepsychiatry.com/subscribe. All right, let's get to the episode. It's going to be a good one. On Medicine Redefined, we were just talking pre-recording about what you do with lifestyle telepsychiatry, and you are the first psychiatrist that we brought on to this podcast. So Altamash and I are definitely super pumped to be talking about something, that is bringing a lot of awareness now in today's world with mental health, and especially the new hotline number coming out. So this is definitely going to be a very, very interesting episode. So thank you so much for coming on.
Of course. Thank you so much for having me. Super excited.
Absolutely. So let's backtrack, right, to your journey. I mean, you have had extensive training. You've had, I believe, 2 masters, right? And then as well as psychiatry residency. So take us through your interest in psychiatry. When did that start, and what was kind of your early vision?
Yes, great question. So I think I've always been interested in psychiatry ever since med school. Because I've always wanting to help people, especially, as humans, we all experience ups and lows, especially in their low times. I think it's such a privilege to be able to help them get to the best version of themselves during the downs of the downs, the lows of the lows, right? And with regards to my master's, though, just for a little bit of background, I was born and raised in Indonesia, so I'm not from here, and I moved here to California to actually get my master's in applied psychology. So I moved here to go to USC for that. It wasn't for medicine initially, and after my master's, I dabbled a little bit in business consulting. But one day, I woke up and decided, hey, I want to go back to medicine and I want to become a psychiatrist here. And that's when all the magic happened. In terms of the second master's in psychopharmacology, I did it within my fourth year of training, so as a PGY4 in psychiatry residency. And the reason for that is first and foremost, as you can tell, in psychiatry in general, prescribing psych medications, when indicated, of course, is our bread and butter. So it's always important to know more about the subject, so to speak. But especially for me, given my focus in perinatal and sports psychiatry, it became even more important for two reasons. Let's take an example of perinatal psychiatrists, right? For moms, the main concern, understandably, is when you take a medication, a psych medication, when you're planning for pregnancy or when you're pregnant or even beyond when you're breastfeeding, there's always that concern of whether this medication may or may not affect the baby in any way. Whereas for athletes, there's always the concerns of taking medication that may inadvertently affect their athletic performance, right? Could be in a good way. Let's say if they're taking propranolol, it might improve tremors and therefore is considered doping in certain sports. And obviously, they don't want to do that. Or it might go the other way. It may impair their athletic performance. Let's say if medication cause weight gain or lower heart rate. In the case of endurance related sports, it also might be detrimental for them. So that's the reason why these two masters, I guess, come about.
So that's really interesting, right? So you bring up the point about how it can inadvertently affect performance. And the other thing to keep in mind, you bring up the doping point. I think that's something that we always have to be cognizant of, right? So I have a sports medicine background, and we always get trained to screen for this. And then also individuals, one of the most prevalent medications is medications for ADHD, right? Right. So Adderall, Ritalin, those kinds of Vyvanse, those kinds of things. And that also always needs to be registered, and it's also a stimulant, so it can be abused and can be an ergogenic aid or performance enhancing drug. So I find that to be really interesting because we had a previous guest who came on here and really talked about the benefits of exercise in pregnancy and the postpartum period. And we all know that exercise is a tremendous stressor, right? And of course, I mean, I don't know if exercise is a greater stressor or pregnancy is a greater stressor, and the postpartum period is tremendously stressful too, with all the changes that a person's body goes through, and then making them or advising patients or clients, hey, that you need to continue exercising because it's going to help recovery and have a host of other benefits. Is going to be challenging from a provider standpoint. So I can see the parallels of how you can have those interests, but I think to the layperson, they might not see that, right? So I'm wondering, how does that inspiration even come about? I know you kind of highlighted how you had two separate interests and you're trying to bring them together, but did you have a significant experience or something like that were like, okay, why I'm really interested in this, but I'm also interested in this, or like a personal story, something like that?
Yes, absolutely. I'm glad you brought it up. So, for me personally, these two areas, sports and perinatal, my interests come from a personal level. So, let's talk about sports first. I was a former student athlete back in the day. So, because of that, what better way I think to pay it forward than to combine these two loves, right, of my life, psychiatry and sports, and becoming a sports psychiatrist myself. And I think for a lot of sports psychiatrists, they may come from at one point they were former athletes themselves, perhaps. So they might be able to understand just the unique challenges that an athlete may face, injury, concussion for some, overtraining, performance anxiety, things like that, and may know a little bit more about the ins and outs of how things are done in sports. In addition, of course, of the training, the actual clinical training on dealing with this specific situations and specific medications when indicated when treating athletes. So that's my motivation behind the sports part of things. In terms of the perinatal psychiatry side of things, actually became a first-time mom during my training, my third year of training. So that makes a huge impact in terms of my interest in perinatal psychiatry, because I myself also have the same thoughts of, like, oh, what's going to happen when baby comes? Oh, during pregnancy, is this the right thing to do it? Is this the wrong thing to do it? Just all these things. And then after the baby comes, obviously, feeling burned out, feeling like I'm pulled in multiple directions with working full time, being a mom full time, and all that. And I think I can be having experienced those things firsthand. I can definitely relate. And also, I'm devoted to helping fellow moms in that sense to go through all that in terms of their mental health as well.
Yeah, I love that, right? I mean, so it's instant buy-in, right? Instant credibility with the patients, the person sitting across the table or chair, whatever, from you. Because I think we've talked about this before, that we're just humans as travel by nature, right?
Mm-hmm.
And so when you have somebody who speaks the same language, quote unquote, it makes it easier to register and really follow their advice or the recommendation. I'm wondering though, in your profession specifically, where you're having these incredibly sensitive conversations, and there is a need to be tactful in how you approach it, do you find that you are, or that you're more likely to share your personal experiences to get that connection with a person, or is that something that could potentially be disruptive to the physician-patient relationship?
Very good question. So my answer would be it depends. As always, especially in psych, perhaps it's a case by case basis. But in this case, I would say if it helps the relationship, the therapeutic relationship, uh, I would have no problem disclosing that, right? Just like you said, they might be a little more inclined to or motivated at least to hear what I need to say because they might see me as, oh, this person have been there, has experienced the same thing firsthand and whatnot. But of course, if it's unrelated to their struggles, it might not have the same effect. So I wouldn't do that in that case, if that were to be the case.
Yeah, absolutely. Sarah, I wanted to transition into the lifestyle medicine aspect of psychiatry, right? So, personal story, when I was first truly interested in medicine, I love psychology, right, through high school. And I thought I was going to be a psych major in college and eventually go on to do psychiatry. Then when I started shadowing, right, in my pre-med years, I started realizing, like you said, the bread and butter is more of the pharmacology aspects of it, right? And figuring out the which medications you want to give. And, for me, that was kind of like, oh, it's not really up my alley. I want to do more exercise, more lifestyle. And I didn't really see how you could truly change more in quote unquote a natural way, I should say. But I'd say about 3 to 4 years ago, when I started on social media, I started seeing more people write about holistic psychology, holistic psychiatry, adding nutrition. So, can you just break down what lifestyle medicine means to you and exactly how do you envision it through your practice?
Absolutely, that's a very great question. So, what it means to me is, and I want to use an example, a personal story for this. So back when I first started my outpatient psychiatry, that would be third year as well for us. I get more time to get to know the patients, their
Mm-hmm.
stories, and their lifestyles, right? So that's when I realized, hey, a lot of, if not most diseases or most conditions in psychiatry, if not all, are chronic conditions, just like, let's say,
Right.
diabetes, high blood sugar, right? So in case of chronic conditions, yeah, sure, we can prescribe meds to help, but it might not be enough because of several reasons in terms of their lifestyles. If we ignore, let's say, the nutrition, they took the medications, but they keep eating highly processed sugars all the time, what's the point? If we give the medications, but they're not exercising, not being physically active, their insulin response might not work as much. So what's the point? If we give the medications, but they're not sleeping enough, they're being stressed all the times, their cortisol or stress hormone levels up to the roof, affecting all this insulin, glucose response, and whatnot. What's the point? So I thought to myself, it might be a good idea to incorporate in a systematic way,
Mm-hmm.
incorporate lifestyle changes in addition to all our regular psychiatric care in the case of psychiatric patients or mental health. And that's when I actually came across the term lifestyle psychiatry, which I believe was coined by a Stanford psychiatrist,
Okay,
Dr.
I
Nor.
see. So, quick follow up then. do you have a specific set of patients in mind then? Because when I'm thinking about, changing behavior and trying to get the message across and then trying to track that behavior, you need to have obviously a patient with capacity, right? Somebody who's alert and oriented. But what about those patients
Mhm.
who might have schizophrenia or bipolar disorder? How do you tend to manage, is it still possible to do lifestyle medicine in those specific set of populations?
Definitely. So you're 100% correct. I think the quote unquote higher functioning the patient is in terms of just their, you know, cognitive function or even being psychologically minded, being so invested in their own health, wanting to take parts in their care is absolutely important and perhaps the ideal, the dream patient to incorporate lifestyle psychiatry techniques. But in the case of, let's say, a schizophrenic patient, bipolar patients, we might still be able to help them, especially when they're not in that acute state, acute psychotic state, acute manic state, perhaps. And we could always take it step by step, meaning it doesn't necessarily have to be a full on lifestyle intervention, right? That it encompasses nutrition, exercise, sleep, stress management. Perhaps it's just one stress management techniques that we want to recommend to them, just deep breathing, for instance, or just the getting enough sleep part by way of advising sleep hygiene and then take it from there. So it depends on the patient, but it's definitely doable.
So I'm glad you brought up high functioning professionals, right? So I'd like to take this time to kind of transition into one of the highest functioning professions that we know, and that's physicians, particularly residents and really trainees of any kind, because what we know is that's arguably the most stressful
Mm-hmm.
time in our lives, right? And then you mentioned adding a baby to the mix. I can't even imagine something like that, or really anything else that that's challenging during that time. And I remember coming across a study maybe a couple months ago. This was maybe published back in JAMA in 2015. I'm talking about the prevalence of at least maybe it was depressive symptoms versus depression. I can't remember exactly. At least a quarter of the residents expressed that right at some point.
Mm-hmm.
I'm willing to bet that a small fraction of that actually seek help, if any at all. You could probably speak better to this, and I know you've done some work, during your training and during time to help facilitate the process where people can kind of reach out, seek help. And, we've talked about some strategies before. Shout out to Robin Tiger, who came back on from Stress Free MD, who talked a little bit about this. And she is a radiologist by training, but really works with a lot of professionals to kind of help decrease stress, if you will. But I want to go a little bit deeper in that, right? I want to talk about like actual pathology, depression, anxiety, things that are or at least anxiety, partly that makes us really good at our jobs, but also can be overwhelming and can be detrimental. And certainly long term, pathologic anxiety, out of control anxiety, can be tremendously harmful. You talked about insulin response, you talked about cortisol, things of that nature that we don't think about in that acute phase. I know I packed a lot in there, but I kind of want to get your sense of the state of training and how trainees are handling it, and what potential strategies could there be that could make that process a little bit easier for people to seek help.
With regards to being a trainee specifically.
Yeah. Let's keep it focused, otherwise we could be here forever.
Right, definitely. Yes, so I think first and foremost, the most important thing perhaps is to recognize uh, the problem, right? Or when it is a problem. So in terms of psychiatry, everyone can feel down sometimes. Like you said, everyone can feel anxious with the coming exams or upcoming exams and what have you sometimes. But when these feelings, one, started to cause intense, severe distress, or two, it starts to interfere with your day to day life. So it could be impacting your grades, your work, your relationships, then it's a good idea to seek psychiatric help. And in terms of in trainings in that setting, it might be a bit difficult because there's a lot of not only stigma associated with mental health, but perhaps perceived repercussion, right? What if people find out? Am I going to get kicked out of the program? What would be my reputation? How can I still apply for licenses and things along those lines? So it might be a bit tricky, uh, but there's always an option to first reach out to, your trusted mentors. If they're in psychiatry, that's even better. They might point you in the right directions. You could always seek help outside of your institution if privacy is of concerns. You can first reach out to therapists, psychologists, or when more or greater help is needed, you could always find a psychiatrist as well. And I would like to highlight it's very important to do it soon rather than later, because not only perhaps you can prevent it to becoming something. So let's say burnout, you can prevent it to become a full-blown depression, but also you could perhaps prevent it to become more severe than what it already was.
I'm glad you brought up this perceived idea of repercussions, right? I know that the ACGME in the past or like the last 2 years or so has really made a strong push for wellness, right? And that's one of the core things that they address programs as. I think you were a chief resident, right? And so was I. And so, we had the privilege of kind of being involved in a lot of the ins and outs of the programs, at least from the administrative standpoint. So we know that. That being said, though, tradition and culture that's been laid out for hundreds of years, that's really, really hard to break. We talk about the medicine being this gigantic ship, and it's going to take a long time for it to turn around. And so a lot of things that you're talking about, I mean, it sounds great, but I can count on more than two hands and people within my inner circle who've had experiences where they need to take a step back, but they're not able to for a multitude of reasons. And one of them could be because the same anxiety or pressure, if you will, of performing is what makes that person good at their job and makes them recognize and kind of feeds that ego and what everybody praises. And so, the stigma thing that you talk about. And so if you now say, hey, listen, I need help, or this is actually hurting me, I think it's a little bit more complicated than just the stigma aspect because, if you have to take time off, you have to extend training, right? It's long enough as it is, depending on if you're going to do more fellowship or whatnot. And we have loans and all that kind of stuff, so you don't have time for that. But most importantly, I find that just reaching out or even reporting is very, very challenging. How do you foresee that process changing, where the friction of bringing it up, not having maybe to find that quote unquote trusted mentor, but the friction of, hey, I'm going to report this, and the barrier is not so great. Am I making sense? Did that question make sense?
Sorry, just to clarify, in terms of other people like chief residents reporting on someone, or
not just chief
themselves?
residents, right? I just use that because a chief resident is a very high stress job, right? Within residency. I just mean really any resident. But in terms of, you talked about step one is recognizing, right? And I think sometimes people do recognize, but after you recognize, you just tell yourself, I just got to get through it. That's it. 2 years, I got to get through it, or 6 months, I got to get through it. I see that finish line wherever that is, and I just got to get through it. But that's a short-sighted approach, right? Because I think what happens is people get on that wheel. If you just get through it 6 months, that's another 6 months you just get through, and it's another 6 months. That's another 6 months. So I'm wondering if disclosing that, hey, something's off, if the friction or the barrier is low, people might be more likely to do that. So do you foresee that process being better?
I see. Got it. So I would like to think so. And so just a couple of examples. First of all, let's take the anxiety part of it, right? You mentioned that, for some people, the anxiety might be at least one of the factors that help them to get things done, to be good at their work. Which makes sense because back then, the root of anxiety, back in our ancestor days, is to help us survive from a threat, like physical threat. So for instance, back in the hunting days, if there's a bear, then this anxiety would alert us to not get eaten by the bear, to physically survive. But in this days of age, a lot of things are perceived as survival threat and can create anxiety, like upcoming tests, driving somewhere, you're afraid of driving and whatnot. So it could go both ways in terms of anxiety being helpful in certain scenarios versus not. It's not helpful when it starts to impair your day-to-day function, right? And to your point of so when to seek help, let's say, should I just power through the 6 months and then power through another 6 months and so forth? My answer to that would be, especially in anxiety and just in general with these mental roadblocks or mental challenges, if we just let it be, it won't go away. Especially for anxiety, if we avoid it, it's just going to snowball this anxiety state into bigger and bigger and bigger of an anxiety, and it might at one point just disrupt our performance or our functions. And the second part of the questions in terms of how healthcare might help or might be more helpful in this days of age is I would like to um, throw the telemedicine aspect there here. So, because of COVID, it became very popular, telemedicine, including telepsychiatry visits, right? And the reason why it might be helpful is for several reasons. One, time. As residents, as high functioning professionals, time is very, very valuable, like you said. If we miss a certain, you know, a week or 2 weeks or what have you, we might have to extend our training for however long. Uh, so no one wants to go through that. So with telemedicine, you can eliminate the downtime of, let's say, waiting to be seen by the doctor, your commute time back and forth. So all those valuable time, you can still use it to work and then just be available for the duration of the appointment. Two, in terms of privacy, right? You don't really have to go be there in an office, risking people might recognize you in a psychiatrist's office, let's say, but you could do it at the comfort of your home when no one knows you have a psychiatrist visits. And then the other thing as well, perhaps to consider, is there's an option for cash-based or non-insurance based care, which might be more confidential for one, because your records, it's not there in the insurance records, right? So when you're applying for things like, let's say, malpractice insurance, disability insurance, things like that down the road, it might not be a part of it per se. And also because it's not an insurance based, cash based, the doctors would have more leeway in terms of your care, for instance, because some insurance might not cover certain medications, but in cash practice, you could still prescribe those medications, or some insurance might require extensive documentation that takes up an actual patient care time. So you can still get that time in a cash based practice, so to speak. So those are the two ways on top of my head that I think might be helpful in this case.
No, I love that. That's really interesting, though. I was familiar with how when applying for a disability insurance policy, your records are fair game,
Mm-hmm.
even the mental health records, which is really interesting because they're more protected. Like I have to break through 7 glasses to be able to look at somebody. So that's interesting. Not actual glasses for those who are not using EMR, but there's this thing. Never mind. But malpractice insurance, how can an insurance company, so what you're saying is, let's just use a case study, right? So I'll just use myself for an example. If I had sought out behavioral health or mental health at some point during my training, now that I'm attending and I'm applying for malpractice insurance, that could affect it negatively.
I'm so
Why is that the case?
I'm so sorry, Altamash. My pregnancy brain is not working correctly. What I meant to say is disability and life insurance, not
Life insurance. That makes
malpractice.
sense. Okay. Gotcha. Okay. Yeah, that makes more sense. Okay, awesome. So I'm glad you brought up the telehealth thing. I think that's certainly changed the game in terms of how we practice medicine, how we will continue to practice medicine. So we'll come back to that in a second. So let's park that. I want to stay on this thread of recognizing, because it seems to be the most important step, and that's why you brought it up first. There might also be times where, again, training is an intense time. I come back to that just because I'm fresh out. And you create these bonds with people, right? And so whether it's your co-chiefs or your co-residents, and you see somebody,
Mm-hmm.
and you recognize it. Maybe they recognize it and they haven't brought it up, but you recognize it. And you're like, okay, you need to take a step back. Again, this is a very sensitive thing. So is there an appropriate way to, again, quote unquote, call out your co-trainee, not publicly, but to approach them and say, hey, listen, you need help, or do you need help? Or, some way to do that. If so, what might be some things that come to your mind on how somebody could do that?
That's a very good point, to discuss. So I think first and foremost, just like with anything, right? In such sensitive situations, one-on-one approach would be better, of course. And it also depends on how close we are to that person, right? For example, if I only say hi and bye to someone once a week or so, whenever I see them in the hospital, I probably wouldn't be the best person to approach them with such sensitive topic. But let's say we're close enough, and then there's an opportunity for a one-on-one conversation. Perhaps the way I would phrase it is just to get their buy-in, kind of highlights, not in a judgmental way, of course, in the most empathetic way as possible, as much as possible, um, how it affects their life, things that matter to them. So, for instance, if they're really concerned about an upcoming exam, like a board exam or something, then you might bring up the point of, you seem like it's these days it's hard for you to concentrate. How's your score looking in the practice Q banks and whatnot? If relationships is the most important thing to them, perhaps you can bring up the topic of, yeah, I you mentioned to me that you had several disagreements lately with your wife, with your husband, and whatnot. How are things then? And then after helping them realizing that there's a problem in terms of day-to-day function, then take a step back and go further into the conversation in terms of symptoms and
Yeah, I like that,
help.
right? It's about personalization, and rather than making it about the culture of the organization, it's actually about what that person's day to day looks like, right? And really opening their eyes to their other priorities, right? That we can't forget. And I think so many people that go into medicine just think residency, training, doctor is the priority in patients, right? And they forget to look to see that, hey, a doctor is what you do, right? It's not necessarily just who you are. But I want to dovetail off Altamash's
Hmm.
questions because both you guys were chief residents, and Altamash, you jump in as well in here. So, they always say organizations and the culture of organizations don't change. It's the people that change, which in fact changes the culture, right? So I'm grateful, being at Penn State
Hmm.
Hershey. I have an awesome program director who's very much on top of wellness. If I have a terrible call night and don't get much sleep, she'll say, "Hey, just text me if you're in clinic. Like, just come 2 to 3 hours later, get your sleep in or something." Right. So the culture that I'm in kind of stayed throughout, and I think the people that we kind of recruit also help that. But we also know that there are very awful programs out there that are super, super terrible in terms of work hours and not letting you go home or not being able to see doctors or dentists. What are maybe one or two actionable items that Altamash and Sarah, that you guys think can make a difference, right? From a chief resident standpoint, at least, because you guys are at least, at the top of that leadership. So for any listeners out there who are residents or in program leadership, hey, these one or two actionable items might make a difference within the organization to help improve the culture.
I'll let you get the first
Oh,
word since you're the guest.
sounds good. That's a very
I
loaded
know. I
question.
guess I guess you can go in every single direction with this, but I don't know if there was something that you maybe implemented from your end.
Right. So I think you're absolutely right, right? When the culture from top to bottom of an organization is may if I may say quote unquote toxic, it's really hard for individuals even at leadership position to change that in a second. Perhaps a thing that comes to mind would be to focus on what we can do on a personal level. So, for instance, let's say you know, even if someone's sick, they still have to come to the hospital, finish their call hours, and just no excuse. Perhaps we can try to find someone else to cover in that scenario. So even though in terms of organization, it's not allowed, it's not possible, but at least they feel that, oh, okay, someone cares about me enough to kind of cover for me for this specific call when I'm not feeling well. Um, just would be an idea on top of my head.
Yeah, I like that. I would just add, I mean, again, yeah, to reinforce the point, I think a lot of it really has to do with, I really like what you said, Darsh, about that people change and then that changes the culture, right? I think that's certainly true. I think I've seen that personally. If I could think of one thing, I think communication is really, really important. Effective and clear communication. I've had people who try to derail a culture, and when people are like, if you have junior residents or really anybody, and you're creating a call schedule or you're doing anything like that, and you're finding coverage, because I think as a chief resident, that's part of your responsibility. Cryptic messages of like where somebody has to be for some type of appointment, or some things don't make sense, because you brought up the dentist and doctor thing, which is it's important, it's necessary, but we're also physicians, and yes, I'm a sports medicine provider, but I also understand how the cardiovascular system works. So if you're making some weird appointments and you have some, like, you know what I mean, like, so you never are, I don't know, I shouldn't say allowed to, you never want to ask somebody, hey, like, what's going on medically, if they don't feel comfortable disclosing that. But at the same time, we're physicians, we're not stupid. So clear communication, I think that's really, really important. And some people will try to game the system again. And I'm not sure if that's a chicken or egg situation, in terms of speaking of the culture, if that kind of derails it, but I think that if you are a junior resident and you do have chief residents who are in a position where they are responsible for a lot of these things, and that's your leadership, bridge to the faculty, the program director, then I think that this clear communication is really, really helpful.
Yeah, no, absolutely makes sense. Cool. Ultimately, anything you want to else? Any questions you had on this? I was gonna kind of switch topics into either perinatal or sports, depending on what Sarah want to talk about. But all right, Sarah, fielder's choice.
No,
do you want to? I want to dive deep into both, because I think both populations are very important, and both are very interesting, right? I think from a lifestyle standpoint, and there's not much awareness, at least from them. So where do you want to go first?
Your call,
All right. Well,
Darsh. I'll follow
I was an athlete. I love sports. And let me ask, what sport did you play?
So I swim back in the days, and then I play basketball and
Gotcha.
volleyball
Okay.
as well.
All rounder. I like it.
What
So
about
grew up
yourself?
playing basketball, track and field, baseball, and then transitioned to tennis in high school. Yeah.
Oh
So
my, that's a
yeah, no, I
lot.
love sports, and so that's why let's dive deep into this. I guess my first question, as I think about sports psychiatry, you touched on it a little bit, but I'm thinking about age, right? And like, what age should people really get started? Because each sport kind of requires a different skill set. And we also say that sports can teach us at a very young age, which is why a lot of parents, put their kids into sports, right? You have golf, which can teach patience. You have basketball, which can teach teamwork. You have tennis, which can teach really the ups and downs of like the solo journey. So at what age do you think it's important to kind of weave in these lifestyle techniques into athletes?
Great question. So I don't know if I have a specific cutoff in terms of age, but con an important concept perhaps would be uh, one, sports as an active lifestyle, right? As like you said, it teaches so many good things, both mentally in terms of kind of like the mental aspect of things, but also physically, and just get us set up in that healthy lifestyle down the road. So the earlier the better, but with the caveat of there's a research out there that says that early specialization is not as great as sampling a lot of other different type of sports for a number of reasons, right? So for example, if we um, kind of like quote unquote force or have our kids focus on just one type of sports from the very beginning, it might lead to burnout. They might not like it as much, but they feel guilty to give it up. So it's probably better to introduce it early and introduce a lot of different ones and let them choose as they grow up.
Sarah, say a little bit more about the early specialization piece, right? I think that we talk a lot about that in the sports medicine world, and I'm familiar with the reasons why, but some of the listeners might not be, right? We live in a world where some is good, more is better, and more practice, and you got to get on the grind, so you got to practice, get up at 4 o'clock in the morning and, practice 20 hours a day, if that even makes sense, and start earlier on, and therefore you're going to make it to the pros. So Talk a little bit about why that might be more harmful than beneficial.
Yes, for sure. So, let's say we have someone start in basketball, right? From the very beginning, just basketball. It might inadvertently leads to pressure, external pressure, right? Because this kid might, they just don't like basketball. They hate it, but because of parental pressure, peer pressure, the coaches pressure perhaps, or just pressure they put on themselves, to continue to push on, because as you guys know, in sports we're taught to always be resilient, always be persistent, not to give up. We can almost overcome anything. They just push through because of that, just that sole reason, but internally they feel miserable because they just don't like basketball. So it might lead to feeling guilty, perhaps affects their self-esteem and things along those lines psychologically. And also, and perhaps, I'm sure you know more about this, letting them sample a lot of sports might introduce them to more movements, kind of like more principles, more diverse skills that they can use, especially if it starts at an early age, and that could be beneficial as well, in terms of their just life skills in general too.
Yeah, no, I'm glad I asked you that, because I think often the literature that gets published on it is really looking at the biomechanical aspect of it, right? So the same muscles, the proprioception and stuff, that's going to be off. But this psychomotor component that you're talking about, I think is, maybe just as important, if not more so. I think it's probably worthwhile. Some people might not even understand what the role of a sports psychiatrist is, or what the hell sports psychiatry is. Would it be worthwhile to just define, what a sports psychiatrist is, and what kind of, what's their scope of practice, and, where they practice? Are they with teams? Are they employed? Like, how does that work?
Yes, absolutely. So, sports psychiatrists, just like general psychiatrists, we deal with common psychiatric conditions, right? Depression, anxiety, ADHD, PTSD, what have you, uh, in athletes specifically. How it may differ from, let's say, sports psychologists, is, for instance, sports psychologists, they uh, focused on improving athletic performance by focusing on mental skill sets, versus sports psychiatrists would focus on treating quote unquote regular mental condition, mental illnesses in the setting of
Mm,
sports. So within athletes, aspiring former current athletes. In terms of the
right.
setting, how it works, it just depends. A lot of variety out there. So some sports psychiatrist is employed by a team, and therefore, take care of the athletes on that team, new incomings one, current ones, and what have you. Some sports psychiatrists might just be in private practice, so it doesn't limit the athletes in terms of which team they're from and whatnot, but just see athletes in general. So it depends on that sense.
So to use an example for the listeners, when we see, I'm gonna say Nadal, because he's the goat. And when you see him sitting on the bench and with his eyes closed, taking some deep breaths and using some maybe visualization techniques, those are skills that have been worked on with a sports psychologist, right? Is that fair to say?
Yes, I think so.
Uh, and then if you have, I'll use somebody that we've talked about recently. Oh my God, Ben Simmons, and you're talking about a lot of mental health stuff that he's been dealing with, and so he might be somebody. I don't know this for sure. I'm just using him as an example. He might be somebody who's working with a psychiatrist and using all the tools that you talked about before in the tool belt to help address true pathology. That makes sense?
Yes, absolutely.
Awesome. Darsh, you got anything else there before we switch gears here? Okay, so let's kind of make a sharp turn and talk about the perinatal, or psychiatry, and that's your other passion and interest. And you mentioned you have a personal story. You said you're 30, right?
Yes.
That's when you had your
Mm-hmm.
awesome. And so one of the challenges we talked about before, we were talking about not getting enough time off and extending training, and this is not even diving into kind of the abysmal maternity leave policy or paternity leave, parental leave policy that we have, which probably adds to the stressors, right? How does that scope work working with perinatal population is that, during pregnancy, postpartum period, what's the bulk of patients that you'll see if somebody's specializing in perinatal?
It's actually all of the above. So it begins from the preconception planning, right? If you will, if let's say if a bipolar patient wants to get pregnant, as we know, some of the bipolar medications might have an effect on the baby. So even before they're actually pregnant, it's a good idea to think that through, talk about options and whatnot, what to do if they were to get pregnant. And then, of course, during the pregnancy itself, postpartum as well, because a lot of things might come up in this postpartum period. For instance, postpartum blues affect 80% of moms, 20%, so 1 out of 5 experience postpartum mood disorder and anxiety, and things along those lines. It could also be extended to breastfeeding for those who choose to, because some medications get absorbed differently in breast milk. So that's an important point. And, just in terms of reproductive psychiatry in general, it extends even beyond pregnancy, pre-pregnancy, pregnancy, and postpartum. So it deals with things like premenstrual mood disorder, right? Or mood changes that might be associated with perimenopausal period. So things along those lines also might get lumped in that way.
That sounds insane to me because that is so incredibly challenging. And I think that people who are not in medicine are going to have a hard time appreciating it. I think about my wife. She's a pediatric neurologist, right? She's a trainee still, but she often will tell me about patients who are on anti-epileptics. And a lot of those medications are challenged and continue during the pregnancy period. So she has a similar or she has many of the discussions that you're talking about. And for those who don't know, a lot of the medications are characterized in different categories, right? So you have category A, B, C, D, category X. And if I'm not mistaken, most of these bipolar medications and anxiety medications are probably category X. Is that right or no?
I think
Or can you continue them?
so. I would say it depends on the medication.
Right.
And let's say the common ones that come up is lithium
Right.
and Depakote, perhaps valproic acid. Uh,
Yeah, that's what I was thinking of.
right. So those are quote unquote notorious in terms of how it affects pregnancy, right? But then we probably need to dive deeper in terms of one, if it does cause or it does have the potential to cause something in the baby, how likely is that? So, for example, lithium, it may affect the baby's heart, but it's not the chance of that is not as much um, as compared to let's say the general populations. So the pros and
Right.
cons in this case, let's say if a bipolar patient is only doing good in lithium, for one, so nothing else worked. Two, just given the hormone and what have you during the pregnancy and postpartum, probably the manic or depressive episode just might come up, have a higher risk to come up. And that could be more detrimental than the risk of having her take lithium. So it's a lot of juggling the pros and cons in that case, in terms of this medication options. And we always do give several options to the patient. So list the pros and cons, if you will. So let's say in this case, if you take lithium, this is the pros and cons. They're an alternative of
Mm-hmm.
this. These are the pros and cons, and then discuss it further and make a joint decision.
Yeah. I mentioned that this is really challenging to treat. I mean, again, most people know that most things in medicine, it's weighing the benefits against the risks, right? And that's kind of what you're gesturing right there for those who can't see. And I think these conversations are probably more challenging than anything else. I think people might wonder, well, why can't you just switch to different medications like an SSRI or something like that? And what we know is that sometimes it's extremely challenging. People have to sometimes with these psychiatric medications go through 1, 2, 3, 4, the fifth medication to really stabilize the condition.
Mm-hmm.
And the last thing you want to do is to take them off, right? But at the same time, they're also going through a time where maybe you do need to. So, I mean, it just stresses me out thinking about that, those conversations that you're having. But that's why you're the expert and you're the hot seat and I'm not. But I'm also wondering at the same time is, as challenging as that is, right? Because you have 2 patients that you're working with and you have to know the pathophysiology of multiple different processes, from a neurological perspective, again from a physiological perspective in the babies in the pediatric population as well. How do you keep up with the literature to look at that, but also the sports psychiatry, which is drastically different when you're looking at something like that? How do you stay up with that?
That's a very good question. I think, just like all of us, perhaps having a high, quote unquote, high yield resources, right? So if there's any
Mm.
important conferences that kind of sums up all the new updates for both fields, or, the simplest thing would be if you encounter a case, a common case that comes up often and often, over and over again, comes up often, then you just try to look up more information both in the lens of perinatal effects and in the lens of sports effect, if that applies, of course. And then I think in my case, though, what helps me is my personal interest and investment in both areas. So that kind of just propels me to continue to learn about these things moving forward as well.
To piggyback off what Altamaj was saying about how insane like it is to keep up with literature, also just to understand pathophysiology, pharmacology in the perinatal period, right? Especially looking at it from a lifestyle perspective, because now you're throwing in hormones, sleep, which is affecting hormones, right? Affecting mood. Then you have exercise, which is affecting hormones, affecting mood, affecting a bunch of different things, nutrition. There's a whole hodgepodge of things going on there. So it's good to know that awareness and books and things like that are slowly coming out. But from your perspective, what do you think, is the one thing that a to-be mother or a mother who just delivered should kind of be putting on top of mind? Is there something specific that you recommend them to do in order to take care of, quote unquote, their lifestyle?
Yeah, so first and foremost, I think I just want to throw this out there that it's very normal, right? It happens to a lot of us. It's very common to feel this mood fluctuation, feel this, sense of feeling overwhelmed, being pulled in different directions because it's a new stage of life. Motherhood is not easy, obviously. And in terms of lifestyle, I'd want to highlight that in all of these lifestyle techniques, some is always better than none. So let's talk about exercise, for instance. A lot of studies said that even just one bout, one episode of exercise is found to improve mood or to lessen anxiety as well. So don't beat ourselves up if we're not able to stick to our exercise, have an hour routine every day in and day out, every single day as a new mom. Some is always better than none. The other thing, perhaps that I found, at least myself, found helpful in my case, is to multitask in a sense of doing quote unquote mindless thing while um, doing something else. So some exercise, for example, in my case, I bought myself a little stepper and a little floor desk to put on top of my regular desk just to prop my computer up so I can do some work standing. And then while I work, I just, kind of step on my stepper, get my heart rate up at least to moderate level, right? Intensity level, and get those steps in, get those cardio in every day. I know it's not much in terms of, hey, I didn't specifically go to the gym, workout, hop on a treadmill or what have you, but at least I'm doing something in the realm of exercise that could be sustainable, at least in this stage of
Yeah,
life.
absolutely. You're right. It's something, right? And something in this period of your life is going to mean more than nothing. And if that can keep you, mentally fit, why not take advantage of that? And we know that postpartum depression is such a big thing and probably underreported, honestly. So definitely a
Hmm.
big thank you for that advice. Let's transition into telehealth because I know that's something that you're putting into your practice. Now, when most people think psychiatry, right, they're going to think of probably the Freudian aspect of sitting on a couch in person, you with your pen and book, cross your legs, and almost interrogating the client, right? So take us through how
Right.
a telepsych appointment would maybe be different and maybe what challenges or advantages you would find with telehealth.
Sure. So, like with anything, right? Like you said, everything has pros and cons. So, with telehealth, typically, for instance, like I mentioned earlier, you don't have to be present at the office, meaning you don't have to commute to go there physically. You don't have to wait there in person for the doctors to see you. So, what you do is you just log in probably several minutes before your appointment. And then when the doctor's ready, the meeting room is going to open up, and then you start your video session. The cons with that, perhaps it doesn't happen often, but like with anything, technical issues might occur. So imagine, opening yourself up, telling this person, very intimate stories, digging deep into your feeling, and then boom, the screen froze, and you have to redo the whole thing. It's probably not the best experience, but like I said, it rarely happens. The other cons, perhaps, is because it's only um, a chest up, I would say, it might be easy to miss certain subtle nuances. So for instance, if someone's anxious and they are actually restless and they're shaking their legs, which just, kind of highlight their anxiety level even more, you might miss that in a telehealth session. But I think especially for the high performers populations, the busy ones like moms, athletes, students, residents, working professionals, where time is very, very much valued and they're very busy, day in and day out, it could be a great options just for that convenience piece and also that confidentiality
Yeah,
piece as
I do
well.
want to ask. So I know there's a bunch of companies I think that just recently came out that offer like mental health services. How comprehensive do you believe those are, or maybe what are those companies good for that necessarily don't really cover what psychiatry might?
Are you referring to
Yeah,
like a
right.
therapy
Yes.
company,
Thank
like
you. That's it. BetterHealth. I think
BetterHelp,
Cerebral.
sorry,
Yeah,
and
some of
things
those
along
like
those
types
lines?
of companies that are now starting up.
Yes. So, first of all, for in those companies, I would say, or in any type of care, right? You just want to make sure you know who's providing care. So, for example, if you have severe depression, severe anxiety, and you need medication adjustment, you probably don't want to, it's not a good fit to see a therapist who might be a social workers or who might be psychologists that doesn't have training nor have the license to prescribe medications. And then also in terms of specifically controlled medications, so that include stimulants for ADHD, benzos perhaps for anxiety and things along those lines. Uh, right now, given COVID, the regulations is still changing. There's a Ryan Heights Act that basically mentions if we should see a patient in person at least once or more for prescribing these controlled substances, and it's still it's still continuously changing given the state of the COVID pandemic. So perhaps it's always good to keep that in mind as well, because if a company is a pill pusher, so to speak, especially for these controlled substances, it might not be a great fit or a good idea to go there.
So I've heard of BetterHelp, but Cerebral you mentioned is another one. Do these companies do they not have like psychiatrists on board to help manage that aspect of it?
So I don't know it specifically, but what I heard is, for example, for Cerebral, they got into a lot of troubles because they employed a lot of NPs, nurse practitioners, right? And I think their model is for this NPs to either, I'm not sure if in some states they're allowed to practice independently, or in some states where they need supervision, they just have, let's say, one doctor, one psychiatrist supervise an, huge number of NPs, which may or may not imply kind of like the supervision slash stringency of that procedure or of that protocol of subscribing controlled substances.
I see. Yeah, I'll have to look that up. I mean, I'm just learning about this stuff. Like I said, I've never heard of that company, but let's talk about the next thing. I know that we're coming to a close here, and I know that like you mentioned early on that you just actually we might have been offline when you did that, is that you just completed your training, and so you're going into practice and in the real world, if you will. And so what's next for you? And what's your practice look like? You tell us a little bit about your telehealth services. Are you doing something in adjunct to that, or is that your primary thing?
Yes. So for me, for California patients, my next available appointment, which is by telehealth, is in September this year, so in 2 months or so. And you can find more info on my website, lifestyletelepsychiatry.com. For non-California residents, I do offer free additional resources with regards to lifestyles changes, sustainable lifestyle changes, and how it can affect your mental health in psychiatry at my website as well. So lifestyletelepsychiatry.com/subscribe. And you can contact me too on my Instagram at lifestyletelepsychiatry.
Awesome. Well, Sarah, I want to thank you for your time. I know that this is a critical topic that, we've spent some time talking, but like Dar said, you're the first psychiatrist that we brought on, and your perspective is certainly appreciated. I'm excited for kind of what you're doing. I think that overall, I do agree that I think there are more advantages. Certainly, what you talked about, the body language not being picked up, right? I mean, here where we're communicating behind the Zoom screen and we can only see the top half, and sometimes people are tapping their legs and things of that nature. These subtle nuances that actually more people will say body language communicates more than actual words or really any gestures or anything like that. But I think overall, just the availability, opening up and access, that's probably the greatest thing. And so to be able to have that, I think is a big win. But anyways, thank you so much. This has been tremendously beneficial, and I've learned a lot, and I'm excited to kind of have you as part of our network as we continue moving forward to make the world a better place. And on that note, one of the things that we talk about is how can we add the health back in healthcare? And so that's the $1 million question for you now is, how do we put that health back in healthcare?
Right. So I'd like to break that down into 2 parts: healthcare, health and care. So for health, I just wanted to remind everyone that mental health is just as important as physical health. And health doesn't necessarily mean or doesn't only mean that there's an absence of an acute episode of a disease. So much more than that, right? And on that note, on the care part, I think it'd be ideal if we can be more active instead of reactive. So instead of fixing the problem that had already occurred, so to speak, try to prevent it before anything wrong happened. And with that, I think naturally the word sustainable and the word long-term in terms of lifestyle comes to mind.
Perfect. Thanks, Sarah.
Thank you. Thank you so much. And may I also say thank you so much, you guys, for all that you do for bringing all this awareness about lifestyle and trying to affect the system, which is very, very much needed as well.
Yeah, it's our pleasure. Thank you.
Thanks.
Thank you.
All right. Thanks for tuning in to another episode of Medicine Redefined. If you're enjoying this podcast and these episodes that we're bringing to you, please make sure to share them so that we can try to build our reach cast our net as wide as possible. If you are interested in Dr. Pospos' services, you can check out her website at www.lifestyletelepsychiatry.com. And of course, if you want to up your medical Spanish game and connect with your patients better, be sure to check out International. As always, our disclaimer, everything in this podcast is for educational purposes only. It does not constitute the practice of medicine, and we are not providing medical advice. No physician-patient relationship is formed, and anything discussed in this podcast does not represent the views of our employers. We recommend that you seek the guidance of your personal physician regarding any specific health-related issues. We'll see you next time.